Boa noite. Buonasera a tutti. Good evening to you all, and welcome to our third CUF digital meeting in anesthesia, a conversation corner between anesthesiologists chatting about medicine, anesthesia, and science, sharing experiences, tips, and learnings. One clinical session under the scientific scope of CUF Academic and Research Medical Center, to whom we thank all the support and encouragement. These CUF digital meetings are something that we created to help time go by faster in times where the time goes back so slowly, just like Madonna said. And for tonight's evening, we have set, I'm very proud because I think we have set a meeting with biblical proportions. Peter and Paul, Pedro and Paolo, two of the most iconic and influential anesthesia missionaries, worldwide renowned, witnesses and converters of generations of young doctors, in which I include myself, to the wonders of our specialty, and advocates for raising the educational and scientific standards of anesthesia, spreading the word, and in webinars, social media articles, scientific articles, spreading the word. Here with us tonight, talking about that Leviathan known as coronavirus. So thank you so much, Professor Paolo, Dr. Pedro, for joining us in this third meeting on the CUF digital meeting in anesthesia. But now presentations. Professor Paolo Pelozzi, Milanese, where he grew and studied, graduating magna cum laude in medicine and surgery. He's currently the chief professor in anesthesia intensive care and director of the specialty school in anesthesiology of the University of Genova, as well as head of the anesthesia and intensive care unit of the San Martino Polyclinic Hospital in Genova, Italy. He was president of the European Society of Anesthesiology in 2010-2011. I was there in Helsinki, where you signed the Helsinki Declaration.
Good evening to you all, and welcome to our third CUF digital meeting in anesthesia.
He's actually member of the Council of the World Federation of Societies of Intensive Care and Critical Care Medicine. He's author or co-author of hundreds of original
of CUF Academic and Research Medical Center, to whom we thank.
Things he has, just to highlight you, has an age index of 70. The age index, it's a metric that says that at least 70 articles were cited 70 times. It's enormous, it's gigantic. And also with him, Dr. Pedro Mourim, another Portuguese anesthesia reference, chief of service of anesthesiology of Hospital Santo Antonio in Porto. It was a professor, associated professor from 2001 of medical therapeutics in the Instituto de Ciências Biomédicas Abel Salazar, co-investigator in numerous studies founded by the Foundation for Science and Technology in Portugal. He is also orientator, mentor of several master theses, PhD theses. He co-founder of startup company where is developing solutions for personalized anesthesia, and is also ultra marathonist, more than 105 official marathons and ultra marathons, principal investigator with clinical studies with athletes, physical preparation, some athletes. So we have all the conditions now to be here, have a nice evening talking about coronavirus. And I will start by asking Dr. Pedro if he can tell us briefly and with general brush strokes, how important were you both, Professor Pelozzi and Dr. Pedro, in awareness of Portuguese medical community in the fight against COVID?
Buonasera, ciao Paolo, boa noite, hello everybody. It is a pleasure to be here, and I'd like to start by thanking CUF and my good friend Vitor Oliveira for inviting me. It is a pleasure to share my views and to be in the company of a very good old friend, Paolo Palozzi. We've worked together for many years. We share many interests. We have a lot in common. And it's a pleasure to enjoy a conversation together with many colleagues who are probably spending their evening listening to us and interacting with us, hopefully. So thank you. It is indeed a pleasure. Thanks for the introduction, somewhat excessive. And I don't see myself as a missionary. I think Paolo doesn't see himself as a missionary as well. I think we're more like long distance runners, resistance, um, probably being capable of resisting several temptations and stay on track, not deviating from principles and from good science and a humanitarian approach to medicine. Paolo is an incredible scientist. He's a reference worldwide, namely when it comes to ARDS, or now CARDS, but is also an extraordinary human being. And I've witnessed that many, many times. He's a very humble and gentle person. And
What happened in the beginning of March? Tell us, just to get all the audience tuned in. What happened with you both in the beginning of March?
That's exactly what I was getting at, because he always finds the time to help others. What happened is that we all saw coronavirus increase in China, then reach Italy, but every single country in a way was in denial, like face cancer diagnosis or something like that, and we don't believe it will happen to us. And when it started hitting Italy seriously, we still had very few cases. And the news from Italy were very few. And there were really no accounts of what was really going on inside the hospitals or the intensive care units, because everything happened very quickly. Our colleagues there were very busy and the news were not still focused there. So what happened on the second week of March, namely on the 12th of March, Portugal had only a handful of patients in the ICU or in the ICUs in the country. And we started seeing some video clips of terrifying scenarios in Italian ICUs. And the word was that these were fake, that these were invented, that some people were showing these videos just to scare everybody. And none of us was really sure about how serious the situation was in Italy. So on the 12th of March, I decided to call Paolo because I knew he could tell us the truth. Paolo replied by a text message saying that he was too busy. This was a Thursday. He only had some free time on Saturday, too busy with Corona, the message said. So I waited patiently until that Saturday morning to talk with Paolo, and he had half an hour to speak with me and to describe exactly what was going on in Italy. And it was really serious. The ICUs were already overwhelmed with patients. They were short of resources, short of staff. They had to invent new areas to treat patients, and he warned me about how serious it will be here in Portugal as well. He told me that we had to be really tough to be able to deal with the workload that was coming in our way. And I started telling one or two people about this, and these news were always received with doubts because we feared that it was a terrible scenario. Also, because we knew in Portugal that we have one of the lowest number of ICU beds for our population. It scared us because our health, our own health was in danger. We knew that we would be called upon action. So the reaction in a way was to deny that such thing was really happening. But the source was Paolo Pelosi, and Paolo Pelosi is very well known. He is a reference. So I decided to publish on the internet what Paolo had told me. And I made a point of putting Paolo's name. This is the person who told me this. And I signed what I wrote. So this is Pedro Amorim. You can check with me if it is truly coming from Paolo Pelosi. And minutes after I started publishing this on a closed group of anesthesiologists, it started to spread like the virus across the country. And I started getting calls asking me, is this true? Is this really you who wrote this? Is this really Paolo Pelosi? And the reaction was emotional because
Pandemic. It was a pandemia
you
of
can
reactions.
tell me what you felt when you, before I tell the rest of the story, what did you feel
Yes.
when you read
we,
the
we felt touched, we felt, and we felt just it was like in short messages, and we all spread it, and I was one of the one that asked you. They are asking me if you can call to the newspapers just in that Saturday to assure that were Professor Paolo Pelosi one description of the scenario. But
and then the problem was that the authorities were not reacting as they should. I have here the newspaper from that same day, and the news about Italy are 10 lines, only that. And the authorities were not considering yet closing schools or recommending that people stay at home. But a few experts were already claiming or calling on the authorities for action. And what happened is that a very instrumental person read my text on the internet. And this was the Dean of the Faculty of Medicine in Lisbon, Professor Fausto Pinto. And on that same day, the 14th of March, he wrote an open letter to the Prime Minister that was published on our main newspaper, saying the title was, "Please,
shut down the
for
country.
for the sake of your health and our health, please close the country." And in his letter to the Prime Minister, he wrote, as an argument to support the need to take action, I only add this, a quote from a respected Italian intensivist, Paolo Pelosi, and he copied the text that I had written. And that was really important to convince the Prime Minister, and also before privately, and hopefully nobody is listening to us, so I can share some private information. But first, Professor Fausto Pinto managed to convince the President of the Republic. And then with his help, and with this letter, he convinced the Prime Minister. And to me, that was what really triggered all that happened afterwards. And it was
Would
not
you say?
just this initiative, a few others, other people also played an important role, but definitely having this information coming from Paolo Pelosi changed totally the scenario. People believed because the source was credible, and that promoted action, and it resulted, many people say, in the fact that Portugal reacted on time in a way, and that's probably because the reason why our death rate is lower than in other countries. That is the reason why our ICUs didn't become overloaded. That's the reason why we could afford 2 weeks to open new spaces for ICUs and to cope with what Paolo was telling us that was going to happen, which is what happened in Italy and in Spain, but hopefully in a very reduced extent. So in this way, many people told me in the past few days to take this opportunity to thank Paolo Pelosi, because we in the country are very thankful to you. Of course, the anesthesia and the intensivists community and nurses, and I know that there are several nurses listening as well, they can acknowledge with what Paolo did. The public doesn't know that, but the result is that the country benefited from the French.
So we are starting here now this upheaval of proposing Professor Paulo to receive a medal in the next 10th of June in Portugal's day, to receive one medal from the President of the Republic to be honored. So Professor Paulo, that's quite true, and Dr. Amorim was quite honest. So tell us about what was your experience with the COVID-19 outbreak. When did you first notice that things were unusual, were wrong, the patients were not the usual kind of ARDS patients that we thought it was a pneumonia from the reports that we have from China? When did you first felt that things were not coming down as you were expecting?
So first of all, thank you very much. Fascinating story. We should write, I'm not saying a book, but for sure, the man who saved the Portugal. We can make a picture, a film. So I'm so grateful, very touched. What Pedro said was unbelievable. It looks like not real, I mean. So the real story is that you are perfectly true, because, for example, in Italy, it's not a question of Italy, it was a question of some regions in the north of Italy. I'm telling of Lombardia, which was the largest one, 12 million people, and was severely hit. Veneto, you know, is just on the east, Piemonte on the west, and Liguria down. We were the third region according to the number of people hit by corona severely, and Emilia-Romagna. So this was why after the lockdown, this avoided that the infection went down to the south and the center, just few cases. So exactly what you did in Portugal, for sure. the first maneuver that saved lives here, that I think that after the first information that arrived more or less from China, I think if the world locked down immediately, we could have saved millions of lives. So
when did you notice that this was not an enemy a known enemy? It was an unknown.
What happened in Italy was the first case was detected in Codogno, which is a small city in the south of Lombardia, where there are a lot of links also with China due to a lot of commercial area. And this was recognized by an anesthesiology by chance. At the time, the only contacts suspected were identified by patients who had contact with China. This patient had no contact with China, but severe respiratory failure, very strange, nobody knew before. And she asked for an exam, for this one, and the patients. And they found corona. Since the time there were no alert, even in intensive care. Now, probably we look at the CT scan in January, and probably there were few cases, but who knows? So the story started on February 21 in Italy. First cases in Europe really recognized. Probably there were some before, that someone told in Germany, whatever. And spread immediately after 3 days. I remember in the night, a colleague of mine from Veneto called us, the group of anesthesiology. Hi guys, we have 2 patients with severe respiratory failure. We put one on ECMO because at the beginning we thought it was respiratory failure. Then I can show you some slides. And then it spread in 3 days, was like an hurricane in Lombardia. And we had the first cases in Liguria on 25, but were patients coming from Lombardia because everyone could move from one region to another. No one thought about the lockdown. That was a big mistake in Italy and in the world, I think. We have to think this has to be the major lesson for the future. Lockdown immediately. And then on 29, so we had first cases in Liguria. It seems everything okay, exactly as Pedro described. Wow. Yes, but what's going on there and there?
Just a normal flu.
Just a normal flu or something a little bit more. Is a pneumonia, a little bit more severe than before. And then on 29 February, 23, 15 in the night, we were called.
Pedro's birthday.
We were called by infectious disease, say, hi guys, we have a patient with corona, because they started to have few patients, but just in the ward. And this must be intubated. And this was the first patients. We were prepared for that because immediately we decided to create the first ditch of the castle. And so we emptied the largest ICU we had, almost 35 beds, and we moved all the patients in another ICU. So we were ready at that time. Very early, remember, at the time.
February 29?
On February 29, we were ready. But because we started with the idea of the castle, we wanted to be prepared. We understood that something was wrong, but I fully agree with Pedro. It was not very clear what's going on even in Lombardia. Not much information around. And not much information from China, so not much information anyway. And so in 1 week, we covered the first 8 beds. Our ICU, the largest was 8 beds, and just a small corridor and a big unit, but they were linked together. And then in 10 days, we covered all the others, but we prepared another ICU of 12 beds, another ICU of 10 beds, and then we were full.
Where did you get the ventilators for that?
No, the ventilator, we have our ICUs were equipped, of course, because the others we got from the operating room at the beginning. So we moved all the operating room ventilators, and we were lucky at San Martino because we had a new ICU, completely new, just without ventilators and monitors, ready for cardiosurgery. Of course, we use immediately for corona, so we were a little bit lucky for that. And we have another ICU that we just closed of other 10 beds for other purposes, and we reopened immediately. So we got
how many beds in total? How many beds were?
In total, we opened 60 beds, intensive care, yes, in almost 12 days, completely full. And then we treated almost 400 patients outside the ICU. We created two big areas in addition to the infectious disease unit, patrolled by anesthesiologists and with the support of some colleagues, pneumologists and the other infectiologists, but patrolled by a team. We have a sort of rescue team of anesthesiology around the hospital. Of course, we increased the people. Now I tell you how. And so in this area, we put all the patients with respiratory symptoms, mild to more severe, and we put the helmet. In more severe patients, I can show our protocol, which was published also. And so we had almost 200 patients by helmet overall and 200 patients without helmet. And we intubated only 15% of patients by helmet.
You used the example of the medieval castle model. What I heard that in a BBC interview that you had. What was in practical terms? How did you organize?
In practical terms, was like this. So as soon as we realized, just a few days after Codogno in Lombardia, that something was going very bad. So we decided, I had a big ICU of almost 30 beds. And then we had for general ICU. Then we had a cardiac surgery of 10 beds. And then we had a transplant unit of 6-8 beds. So we decided to move all patients, non-COVID, of course, to the other ICU. Of course, we stopped all the surgical activities immediately, and just for emergency, of course, for that, and neuro and emergency. So we empty the first 8 beds that were a little bit separated from the big unit, but just next there, is on the same floor. Then we have the chief of nurses, our rooms, and then the other. And we had time to free the other part of the unit. That's why it's important to have different boxes, but huge ICU. I think that this is very important concept for next healthcare organization. Not small ICU, many small ICU. This was a problem in other places. Very difficult to have in a pandemic to control different small ICUs. Small, I mean 8 beds. It's much better.
May I ask a question?
Yes.
So every single day, new initiatives have to be taken.
Yes.
The initiatives came mostly from the doctors involved in the management of patients or the hospital management?
So how
was the relationship with the hospital management? Did you have to push them, or were they leading, let's say?
I can say that we had a support, technical support from the hospital, but I can say that what we did was very few people organizing this. I was myself and the other chief of the anesthesia area, which is also the link with the region. So everything was in the hand in the organization of Dr. Grattarola, who was the other chief, and myself. We we met every day at 10 to 8 every day for 1 hour, 1.5 hours to plan with some other colleagues what to do.
Led the process. You were the ones that
information were given to the hospital direction, and so they supported us in our decision. So very few people decided the strategy from clinical point of view. Then you have the laboratory like this. From clinical point of view, very few people. And also in the region, we created a chat by the iPhone, and every time we had to know how many beds were there and patients. But this was regulated by one person, that was Dr. Grattarola, and the other myself.
What were the main difficulties that you faced at that stage?
The main difficulty was, first of all, to organize the material. So we had this, for example, to choose, take all the ventilators by anesthesia, but they were not enough. So they were not, are good, but when we have to treat these patients, but this was very helpful because we could buy time, 3-4 days, to get new ventilators of good quality. And so the first is to get all the material, the monitors, the link of the monitors, all this kind of stuff very rapidly in 1 week. And we have to be very thankful to all the technical offices that supported us. But we have no problem in terms of device because we try to use everything in the hospital. But we have to, for example, the connectors for the oxygen, for the helmet, for example, it was not possible in the infectious disease to put more than 6 helmets due to the amount of oxygen. So the technical hospital offices created in less than 3 days these big areas with a lot of oxygen pump so that we could give oxygen to a lot of people. So, but this was our idea. So our ideas going to the technical, and the technical was trying to solve. The second problem was the people. So we stopped all the surgical area, everything. The hospital was completely paralyzed, except for emergency. And all our colleagues from anesthesia, they came to support us in intensive care and to patrol the area, the hot areas in the hospital. And this was fun.
And the other specialties, there was like this joke.
Yes.
You risk having an ophthalmologist.
First of all, this was a clear demonstration. I am very proud to be anesthesiologist and intensive care physician, because this was the demonstration that the anesthesiologist, and they put anesthesiologist everywhere, okay? Our specialty.
But you have the need,
we are 300.
You had the need to also to recruit other specialties like surgeons.
No, but I tell you, I mean, the probable question is that we were 360 degrees. So we could do intensive care, anesthesia for the patrolling the area, post-operative, and then I can explain you also the post-ICU. So this was very difficult for others first. Then I can show you this was not pneumonia. This is a complex systemic disease. So you cannot be expert only in this, in coagulation, or in the lung, or in the heart, or whatever. You need a preparation for critical care, but also intubation. For example, around the hospital, our colleagues were intubating patients. My wife, she was in Polyclinic in Milan. She's an anesthesiologist, and she was going to intubate patients with COVID-19, and the same in our hospital. So the importance of our specialty, and I think this should be more emphasized. What about our colleagues? Our colleagues has 2 main roles. In the intensive care, mainly the cardiologist, the nephrologist, and of course the infectivologist, and surgeons, because some patients have hemorrhagic problems. Very few, so very few of them, they came. They were very helpful as consultant in the critical care. Then pneumologists, some of the pneumologists, they supported us in these big areas by supporting patients with some helmets or with less severity, and of course the infectious disease with those patients, however, that they required less support. So, but I think that the crucial role here was made by anesthesiologists, because only the anesthesiologist could have the possibility to treat such a complex combination of systems. And I can tell you more. The sub-intensive care, we created a sub-intensive care. This is very helpful for the future. I think very few centers did that. Just next to the big ICU, one of the biggest ICU, the Letom 35, we created 10 beds. We called was previously for Otorino, and they were moved to another floor. And in that area, we created a sort of sub-intensive care led by ourselves, in which we put the patient discharged from the ICU from 10 to 10 days, 3 to 10 days, before to go to infectious. This is very important.
Post-extubation? Post-extubation?
Post-extubation. not directly to the ward. And this is essential in Corona, because in Corona, 1/3 of the patients after extubation, they feel more or less well. The CT scan is terrible. We have all the data now. We did also the CT scanning after extubation, and they were monitored. There were some problem of coagulation, some problems of again some mild respiratory support and so on. It's essential to keep them strictly monitored in that area. So this is an innovation, I think, in the treatment of some. So again, it's not only a question of the lung, it's a question of the patient. And third, the people. How we got many people so fast. This is what we did in Genoa, but also followed in some other regions. First, we put together all anesthesiologists, anesthesists that are anesthesiologists, but working in the operating room. And the combination with us was perfect, no problem. Of course, we had some, but to teach them something because they were not used to come in our unit, but it was very easy. That's why our specialty demonstrated our strength. It does not depend if you work in anesthesia, in intensive care, whatever. You know the concept. So it was very easy to merge together. From second, we had residents, for anesthesiology, 5 years, and the residents from the 4th and the 5th year, all of them, they were immediately hired, and this is to be recognized by the hospital. They were put with our team, full job, of course, with some always supervision, because we have also senior physicians everywhere, every time, all day. That's why with Pedro, I say I can only on Saturday morning. It was the only day that they can buy to have some shopping, to buy some food. And so we hired all of them. And also we distributed some of them also to the other hospitals to support them. So that's why we try to afford this.
Was fear a problem? Did you have to deal with doctors who were scared to death?
So I think that we changed our mentality. At the beginning, when we started, of course, we had two fears. First of all, to have all patients closed in a box, and we have not boxed enough. Mm-hmm. And the doors were closed in some rooms in the intensive care, or boxes, only boxes. You have to intubate, only boxes, only boxes. And the second, when we started to dress this dressing, the white dressing, it's like astronauts, okay? And the administration at the beginning gave this. But in 1 week, this device, of course, there were no anymore. And we also realized that it was impossible to work with this device. Very nice, very fashion, but completely difficult to manage. No more than 2 hours, pretty sweating. Some people even had some problems with that. And so very difficult. So we decided to have a light cavalry, from heavy cavalry to light cavalry. What does it mean? Just a gown, very light, the glasses, a vision, and then we dressed a very light surgical dressing, and of course 2 gloves. And this was a completely different world. Much better. At that point, we completely changed it. After 4 days, we decided to do that. Don't use what they taught us before. You have to be very light, otherwise you don't see anymore the patient because you have fear. But with this system, it was much easier to change ourselves. Of course, some chloride on the shows when we were out of the zone. We decided at the beginning, we say, we have to treat these patients only in the boxes, but we have no boxes enough, and we're full of patients. So we were completely out of the boxes. So we created a line. This area is dirty, this area is clean. And
have you ever felt overwhelmed, scared, thinking that probably you could not handle with just...
This we were never in major trouble, but there was a period between 20 March and April 5, in which we were near to be the knockdown. And we were very worried. There were the terrible 5 days from Saturday to Thursday.
Which days of the month?
It was between the end of March and early April, and we have 5 days in which from Saturday to Thursday, 5 days where we are nearly to the knockdown. But we resisted. What does it mean resisted? We opened some additional beds, and then we hope we could have another possibility to open more. But fortunately, at that point, the situation stabilized, and so we were.
Did you had the need to...
But we treated up to 60, 65 intubated patients at the same moment.
At the same time, 65. Do you had the need to network with other hospitals in Liguria, private hospitals?
Yes. We had, this was essential. We had a chat, so we could have at any moment to have the situation of each hospital. But there was only one person, that was Dr. Gattarola, who was organizing the movement between patients. And so, of course, I supported him, of course, from this point of view. And we decided that in any moment we knew what to do and which was the situation in every hospital. So the link with every hospital was continuous.
Yeah. Did you had any, there was some hustle in the media that's saying that people aged less than 65 years old were not admitted to ICU. Did you had that need?
I mean, you know that there was a document from the Italian Society. I'm not one of the authors, in which they discussed these issues. I think that personally, I think that the right word should be appropriateness of treatment. So exactly what you do for the hepatic transplantation or other things, or brain or whatever. So appropriateness of treatment. I can tell you that in our hospital, due to the fact that we increased progressively the beds and we did not reach the top, so we could go even more than 60, we never had a decision to do this on this. In some patients, of course, we have to wait a little bit to find the place, but this is the beds. But this is what
there was not
there was no clear. Of course, if you have a patient very, very old with 4 comorbidities, before to admit to the intensive care, we thought 3 times.
Can you please highlight us about the approach? If a patient arrived at your San Martino with symptoms, how did you handle it? So what was your algorithm of handling that patient?
Can you show you one of our
slides?
Slides that clearly shows the algorithm of this, which is this one. Now we share.
Your articles.
I share, and this is exactly the do you see? Now,
yes.
Now I increase.
Okay.
This is exactly what we did in the world. Okay. So we measure the saturation in the room air. This was the pattern. Imagine that we have 50 patients, okay? And then in this big area, with possible to give oxygen at different level. So every patient was monitored for saturation. If saturation was above 95 in room air, okay, you are reassessed every 6 hours. If the saturation in air was below 95, we tested conventional oxygen with or without reservoir at 15 liters per minute. If saturation increased and respiratory rate was below 25, the patient was continuously reassessed. If saturation was below 95 with oxygen reservoir, at that point we started helmet. Others can start. Why we did helmet? You see on the bottom. This was in the ICU, but just as an example outside, because the helmet allowed to have less dispersion in the air. Yes, and then we use the PIP10 at 60% for 3 to 6 hours. If saturation improved, we continue with helmet. If saturation decreased and or respiratory rate increased more than 28, at that point we start to discuss possible intubation. according to the condition of the patient. And in that case, we intubated the patient. With this strategy, we almost avoided, almost, you see, 85% of patients that theoretically should have been intubated. So we only intubated 15% of the patient treated with this protocol, which I think is a good result.
This is a very nice article that you've published, and one thing that you focus is the role of the CT scan at the emergency admissions. Where did the patient here in this algorithm, where did you send him to the CT?
So this was an important story. I show you this because at the beginning, when we started this story on February 29, and for 1-2 days, CT scan was forbidden. Why it was forbidden? First of all, because all patients were always the same. PO2 below 100, at that point patients were intubated. The chest X-ray was bad, but not so bad. This is important. So desaturation, severe hypoxemia, but CT scan not so bad according to hypoxemia. That means that you need to have a problem in the vascular side. The extreme is typical, the thromboembolism. And after the second patient had a thrombosis in the jugular vein. And we say, wow, what's going on? And the third one, he had a pulmonary embolism by echo. We say, this is not ARDS. We have never seen that in ARDS. This is not pneumonia. This is multiple organ disease syndrome, MOTS, COV2. This is a new paper coming out. So I decided to go to the CT scan. I wanted to see what's going on. And we were lucky because the CT scan technician at that time were almost sent to holiday because there were no more need for CT scan in the hospital. The hospital was full of COVID-19. So we say, wow, what we have to do? We convinced our colleagues from radiology, okay, Bob, if you wish, we don't think this can be helpful, but we can do. And they called back all the technicians. They were very happy because they were sent by forced vacation. And so they were back and we went to this area, you see here, these are we with the first patient. And we open it, we say, okay, but this is not only CT scan, we have to do CT perfusion. And no, you was using CT perfusion because why to do so perfusion in this situation with COVID-19? Okay, everyone was skeptical, but then we started to do the first CT scan, which is this one, and we say, wow, yes, look, the CT scan is very, very bad, much worse than the chest X-ray. And then you see here the patterns that we found, the CT scan and the perfusion. And so this changed, in my opinion, and now papers are coming out, the view of, in our view of COVID-19 pneumonia. Because we realized that there were different patterns, as you can see here, where you can adopt different ventilatory strategy, even prone position, if needed. And we also analyzed the perfusion, the regional perfusion of the lung, and we found that there was over-perfusion in the non-dependent part of the lung. So the pattern of perfusion is non-gravitational, which is completely different from RDS. The second, there were areas, especially in the white areas, with thrombosis, no flow there, no flow. So we showed that there was a difference in the perfusion pattern in COVID-19, and more is the amount of perfusion, hypoperfusion, more is the risk to die. And this is even more important than the pattern by CT by itself. So CT changed our view of COVID-19 pneumonia because we realized that it's a different pattern, that the perfusion played a major role, and the densities and in the lung.
Not only a pneumonia. But you did a CT scan just at the admission, or when the patient was not improving?
No, the CT scan was done as soon as possible after admission. We did that also. These are the analysis, but this is just to give you the weight of the lungs. A normal lung is 800 grams. The RDS lung is 1 kilo and around 2 kilos, but this is edema. In the RDS lung is edema.
Water.
In the phenotype 1 is 1 kilo and 100 grams. In the phenotype 3 that you see below is around 1 kilo and a half. The problem is how much this increase in the weight of the lung is due to the edema or to the fibrosis. Now I have all, but I don't want to enter too much here, but I can show you how is the anatomy of the lung. So these are the cryobiopsy. What we did was to analyze the sample of the lung after 20 minutes after death. So it's not autopsy, it's in the cadaver, mechanically ventilated by cryobiopsy in the lung. So very near to the reality. And our patients died quite late. So you see at a minute 25 days. And you see here the first pattern. This is the CT scan. You see areas more or less normal, are not normal, but more or less like this. And you see here in the upper panel, the alveoli, and in black are the epithelial cells. And you see that the epithelial cells are completely broken, okay? But there is a little bit increase in the interstitium, but this is not much edema, and there is not edema in the alveoli, completely different from RDS. Then you can see in the second panel C, these pink areas are the hyaline membrane. So this is what is the anatomical finding in the so-called normal lung in COVID-19. Then we go to the ground glass areas, the typical COVID-19 areas, very much peripheral and with the scissuritis. And you see that if you sample this area, we sample all the lung, of course, you see that the alteration in the lung is very much fibrotic. It's not edema, it's fibrosis that kills the COVID-19 lung. And this is the white areas. The white areas you see, you think that are atelectasis. In RDS, these white areas are atelectasis. When you turn the patient prone, these areas are reopened. We did the CT scan in prone in COVID-19, they do not reopen. Why they do not reopen? Because these areas are pneumolysis, fibrosis, cellular necrosis, but not edema. So it's a complete different pattern, and I can show two other slides that I think clearly show the concept. This is what happens with PEEP in a patients, and we have a series of more than 70 patients now, in which we apply 8 and 16 of PEEP. This is a relatively mild COVID-19. This is an intubated patients, okay? These are the best patients that we had, just to give you an idea. And you see that when you apply different PEEP with recruitment maneuver, we have not much recruitment. So no alveolar recruitment, we fire PEEP in less severe cases. And you can say, okay, now we are talking about this. And you would expect recruitment in these patients if this is edema. You see that there is absolutely no alveolar recruitment, even in more severe cases. So clearly, this area, when they progress to the disease, and this happens also in the ICU, is not edema, but is a progressive fibrosis, lung necrosis, what we call pneumolysis. This is already an idea of a colleague from India during the seminar. He's a big physiology guy. And I like the word pneumolysis, not edema, but pneumolysis. And now just to show you another interesting thing. This is a very old slide that I did with Gattinoni many years ago when we were interested in the movement from supine to prone. And if you see some images, even from ICU in north of Italy, you see many patients prone. Oh, okay, no, we found that prone position might be helpful, but we have to be very careful. Now I explain you why. In the first panel, you see the gray zones are the so-called atelectasis of consolidation. And there are some patients that you turn prone and consolidation remain in the dorsal part of the lung. So when you have an increase in PO2 in these patients, this is only due to a redistribution of perfusion, not increase in minute ventilation. So no recruitment at all. The oxygenation is a symptomatic effect only due to the redistribution of perfusion. In that case, the PCO2 or stays stable or increases because there is no change in the ventilation, the regional ventilation in the lung. While you have the second case below, in a patient in which these gray zones are atelectasis, are due to the compression of the dependent lung due to the increased lung weight due to the edema. In that case, when we prone the patient, this is occurs in the conventional RDS, traditional RDS, you see that we have a reopening of these atelectatic areas in the non-dependent part of the lung. We have an increase in regional ventilation, real recruitment. So in that case, the improvement in oxygenation is associated with a real recruitment, no redistribution of perfusion. And since we have a regional increase in ventilation, we have a reduction in PCO2. Well, if you do prone position during non-invasive ventilation, this is what happens when you apply non-invasive ventilation in prone position in COVID-19. And you see that you improve oxygenation, and oxygenation is going back in most of patients when you reposition as supine. And also respiratory rate in some patients improves. Overall, you have responders, persistent responder, and non-responders.
Yes.
Well, we did the CT scan during non-invasive ventilation in a limited group of patients, but almost 15 patients, during non-invasive ventilation. What we found that the oxygenation improved in 70% of the patients. This was not maintained when patients were repositioned as supine. But more importantly, even if oxygenation improved, we observed a reduction in the lung volume measured at the CT scan, an increase in the tissue mass, and a redistribution of perfusion by CT perfusion, and no recruitment at all. So the improvement in oxygenation by prone in COVID-19 is just symptomatic. And very often it can be associated with an increase in CO2. This is a study that we did many years ago on traditional RDS. And you see that the response in oxygenation and CO2 on the right in prone position is very wide. Some patients improve, some patients do not improve, some patients do not change. So, well, the patient who responded in terms of oxygenation or did not respond, you see the panel on the left down, there's no difference in terms of survival. So improvement or not in oxygenation in prone position was not associated with better survival. On the contrary, the patient who decreased the oxygenation, so were PCO2 responders, they survived more than patients who did not respond. And if you match this with my slide before, means that those patients who had effectively recruitment in prone position due to the edema, they improved survival in prone position. So it's PCO2 response very important in prone position. So, well, what happens in COVID-19 patients? We did the CT scan in prone position, and we also prone almost 35%, 35% of the patients in our units. We had almost 160 patients intubated in our units, in our hospital. Prone position improved in 40% of the patient, plus then 20% oxygen during prone. So effectively, some patients improve oxygenation, not so many as in traditional RDS. But 77% of the patients increased PCO2. This does not happen almost in most of patients with RDS. It's a minority of traditional RDS. So this patient is exactly the panel one. So no recruitment when we turn the patient prone, but just redistribution of perfusion. Further, you have to be very careful when you prone patient because you have to exclude thrombosis and possible pulmonary thromboembolism in these patients. There is a major increase in healthcare professional demand and workload, especially in these patients. And in our series, there is absolutely no evidence that prone position improves survival. So we believe that prone position should be used as a rescue therapy, but not as a standard therapy in patients with COVID-19. This is just to give you some ideas.
Yes. But in your article, you speak about the three phenotypes. Phenotype 1, you have mentioned it. Phenotype 3. Here we learned the L and the low elastance, the high elastance. How do you compare those three phenotypes that you describe in this article with the Gattinoni classification of low and high?
We have to be now clear. So This was just the beginning, so it was published after, but it was written 1.5 months before. There were some difficulties because, of course, these are new concepts and different from others. So really, these are the three phenotypes. The phenotype 1 is a multiple focal, we know now, overperfused ground glass opacities and normal aerated areas. So the PO2 decrease is due to the lobia Q, due to the hyperperfusion in non-aerated, in the well-aerated areas in the non-dependent lung, and more perfusion in the ground glass areas. Then we have
These are the ones that are hypoxemic silences.
Exactly.
These are the ones.
Exactly. And these patients likely benefit for non-invasive respiratory support. But if the disease progresses from phenotype 2, in which you have asymmetrical alteration and ground glass, these patients may require lateral position, and this patient may require nitric oxide. We had a fantastic experience with nitric oxide. Unfortunately, we had only 3 machines, but we have now correlating the response in nitric oxide and CT scan. And these patients are those patients who responded better to nitric oxide.
Do you have in this phenotype 2 pulmonary hypertension? No.
Now, pulmonary hypertension we measured in all patients that underwent, of course, echo. The alteration in the heart, there were in few patients. There were some arterial hypertension, but was not so high as expected. So, I mean, the average was about 35. So it's not low, of course, the double than normal. But very few patients we found around 45 to 60. But even there, we had good result with nitric oxide. Why? Because perfusion here is not like in ARDS. In ARDS, perfusion is more in the dependent part of the lung. Here, as I told you, the perfusion is in non-dependent part of the lung. Then I show you some graphics. And so the redistribution of perfusion due to the nitric oxide is probably very helpful in this situation. Then we have phenotype 3. That was the most common. So I would not separate phenotype 1, phenotype 2. When you are intubated, you are phenotype 3. Only 7% of patients intubated in the ICU, they have phenotype 1. So phenotype 3 and phenotype 2 are the most frequent in the critically ill COVID-19 pneumonia. And if you have some chance not to be intubated, you have to be in the phenotype 1. And to hope that non-invasive respiratory support is going towards a better solution.
Did you find any relation between the phenotypes and the outcome of the patients?
Yes. So what substantially we found, I can show you the graph. One of the analysis, some data are under analysis, is the following. So this is the distribution of the percent of hyper-aerated, very few. Normally, this is at PIP 8, okay? Normally aerated, poorly aerated, and non-aerated tissue. And in dashes is the perfusion defect. So there were 2 factors on survivors and non-survivors. This analysis in the half of our patients. Then we complete with all our patients, were age and Charleston index. But also look at the lung tissue. So these are the non-survivors and survivors from ICU. First of all, you can see that the amount of normally aerated tissue in green is less in non-survivors, while the amount of non-aerated tissue is higher in non-survivors. But most importantly, you can see that the amount of hypoperfusion, so no perfusion really, not hypo, no perfusion, was much higher in the ground glass and in non-aerated tissue in non-survivors. So it means that in those areas of the lung, those patients in which you have microthrombosis, these patients are going to die. Probably some microthrombosis is helpful because you reduce the shunt in the non-aerated tissue. But if microthrombosis is too much, you are going to die. And you see, in fact, that even in patients who were discharged from the ICU, you have some microthrombosis, but much less than patients who died. This means that you need some microthrombosis. Microthrombosis is a physiological phenomena to try to minimize the reduction in the true shunt. While if you have too much microthrombosis, you are going to die. Which are these patients? Are patients who are going to have this fibrosis response, where you don't see anymore even the vessels, the capillaries, You have a real pneumolysis. And then
they were all hypocoagulated. They were all hypocoagulated.
Yes, then we can discuss this exactly. When the hypercoagulation is creating too much areas of vascular defects in the lung. But vascular defects means thrombosis and pneumolysis, so complete destruction in terms of fibrosis of the lung. And then you can see in yellow, you see that the dead people, pulmonary blood volume was much higher in those patients who died in the gray zone, so in the poorly aerated tissue. So if you put together this is also the analysis from ventral to dorsal, and this analysis was performed at the same amount of lung tissue. So ventral, middle, and dorsal have the same amount of grams in tissue. So the distribution in gas volume and blood volume as standardized for the amount of lung tissue in this area. First of all, look at the lung tissue. You have less green areas, and means that you have less aeration, of course, in the dorsal areas, and more non-aerated areas in the dorsal regions with more hypoperfusion. But look at the pulmonary blood volume. You have a completely anti-gravitational distribution. This is completely different from ARDS, where you have a gravitational distribution of blood volume. So that's why you have more blood volume in the aerated and poorly aerated lungs. So let me show here what is our model of COVID-19. So this is in upper panel is the normal lungs. You see a gravitational distribution of aeration in blue, more alveoli in the non-dependent, smaller alveoli in the dependent. And you have more perfusion in the dependent lung regions. When you apply PEEP in a normal lung, you overdistend the lung and you squeeze the perfusion from the capillaries. When you prone the patient, you have more homogeneous distribution and you have more, the perfusion is maintained in the dorsal lung regions. What happens in ARDS? You see that all the alveoli are smaller because you have more edema and you have atelectasis in the dependent part of the lung due to the weight of the edema on the most dependent part of the lung, like a glass of beer or a glass of wine. In the most dependent, you have more pressure and the alveoli are squeezed. And in this area, as you can see here, we have more blood flow. So in the traditional ARDS, you have alveolar capillary damage, you have more edema created collapse, and in this collapse area, you have more blood flow, and you create shunt, true shunt. But the VQ, low VQ areas are very minor. When you apply PEEP, it's very clear. You can overdistend the non-dependent part of the lung, but then you recruit the dependent part, and these areas are perfused, so you improve oxygenation. So in the traditional ARDS, when you apply PEEP and you have an increase in the aeration, increase in recruitment, this is associated with an improvement in oxygenation. When you prone the patient, what happens is that you reopen the collapsed alveoli because they're in the non-dependent areas anymore, and the blood flow stay near to the vertebra. So you have a better oxygenation due to a reduction in shunt. So ARDS is characterized by edema, atelectasis, lower compliance, higher perfusion in the dependent lung region, recruitment with higher pressure, and response with oxygenation is associated with better aeration and recruitment, but not perfusion redistribution. What happened in COVID-19? I don't discuss type 1 because type 1 we don't see in the ICU. Type 1 is the model that you can see outside the ICU. But it's very similar. We look at the type 3. Okay, at the low PEEP, the big balls, purple balls, are the completely pneumolysis alveoli, fibrotic alveoli. And the small dots in blue are the gray zone, are the poorly aerated tissue. So what happens is that you have more blood flow in the well aerated, so you reduce the VQ. You have more blood flow in the COVID area, so-called gray area, patchy, ground glass, so that we decrease the VQ. And what happens in the consolidated areas? Some areas are perfused, some areas are hypoperfused. I showed you before that more hyperperfusion you have, more likely you are going to die. When you apply PEEP, what's happening is not like ARDS. You just overinflate the lung, all patients, they reduce the compliance. None of the patients improve the compliance. And if you have some positive response in oxygenation, it's just to reduce to a redistribution of blood flow towards the aerated lung, but it's not recruitment. So first message is that in COVID-19, the response in oxygenation is not associated, whatever therapeutic maneuver prone, with a recruitment of the alveoli. In fact, when you prone the patient, you see nothing changes except the fact that some blood flow can go down. So you can have just a redistribution of blood flow differently from conventional ARDS. So COVID-19 is a primary ARDS, typical primary ARDS. With pneumolysis, gas volume is substituted by fibrosis and cellular necrosis, and more according to the advance of the disease, by consolidation and not atelectasis, higher perfusion in non-dependent lung region, completely different from conventional ARDS, poor or no recruitment with higher pressure, and the response in oxygenation is associated with a redistribution of perfusion, but not better aeration, which is completely different from what happens in ARDS. So hypoxia in COVID-19 is due to lower VQ in aerated, non-dependent, and in poorly aerated lung tissue, so the ground glass regions, due to increased perfusion in these areas. And higher shunt in non-aerated lung tissue with microthrombosis effect within a certain limit may be partially protected. This is the model of COVID-19 pneumonia that we developed by CT scan.
It's a change in what we've learned and what we thought it was like. You said it, COVID-19, it's not a pneumonia, it's a multi-organ dysfunction, as you said it. And now I was listening to you and I was asking if it is an RDS, as we were told
I think that this is a typical primary RDS. You know that we divided, we can go back to many years ago here. Many years ago with Patricia Rocco, we divided in pulmonary and Gattinoni, pulmonary and extrapulmonary. And look at this. This is RDSP is exactly what is more or less COVID-19 pneumonia. Look also at this, low interstitial edema, more cell infiltration, more collagen fibers, and so on. The question is that in traditional RDS, these are mixed because you are primary, we have also sepsis. In this patient, they have no sepsis, no need of vascular drugs in the early phase. You can have when we have a sobra-infection after 15, 20 days of mechanical ventilation. But I have no sobra-infection.
I have here two questions from the audience, and I remember the audience that you, if you want, you can post questions in the YouTube. The first one is if you used pulmonary ultrasound in your COVID patients.
Yes, we used, of course, this CT scan was very important in order to define the pathology of RDS, of the pathology of COVID-19, and to learn more about these patients. Of course, at the beds, and we did CT scan when? To define the patient when he came to the ICU as soon as we could go, but we were able to go in most of the cases even early. We redid a CT scan during the ICU course if the patient did not improve, and all the time when the patient decreased the oxygenation in order to exclude the pulmonary embolism. So we did also the angio. But at the bedside, we use the echo, and you see that you can clearly differentiate the crazy paving, so the ground glass, pleural effusion, septal thickening, whatever you want. So echography is very important for the bedside monitoring of COVID-19 patients, but and also for the echocardio, of course, echocardio. But I think that CT scan gave us the major, especially the CT perfusion. I think that what we learned is that CT perfusion is the technique in the future to be applied in, not only in this, but we want to move on again back to RDS, traditional RDS, in order to study the perfusion in traditional RDS. But lung ultrasound.
The second question that the audience asked is, how was a typical therapeutic chart on your COVID-19 patients? Did you put hydroxychloroquine, dexamethasone, remdesivir? Well, if you admitted a patient, how did you, what drugs did you put it on the therapeutic chart of that patient?
This is a paper that I think is going to be published or was published, in which we try to put together the different drugs, and you see a lot of drugs have been proposed. So what we know now and what we did. We did not use except the first few days chloroquine. So don't use chloroquine. Don't use. We used, but we have some data also about tocilizumab, which you know is against the interleukin-6 receptor, is shown here. Yes, yeah. Recent data suggests no clear effect. Perhaps there can be an effect to work together with corticosteroids, but we do not recommend as a primary drug. So which are the primary drugs? First, corticosteroids. And now we have the recovery trial. We are very happy. We started since the beginning. As I say, we use methylprednisolone at 0.5, 1 milligram per kilo, then 0.5 after 1 week and 0.02 at third week. The recovery was with desamethasone at 6 milligram, which is equivalent to 35 milligrams of methylprednisolone. I don't know if it's one or the other. The Chinese data were suggesting methylprednisolone. Recovery trial was done by desamethasone. I don't know if there is any difference, but we decided to use corticosteroids. Absolutely very important. Because, and as I say, we did like both in the American Cup, we decided one win and we continued like that. We have now data, however, that the use of corticosteroids, and we just published, was associated with a little bit higher increase in infection when in intensive care. But overall, they are mandatory, in my opinion, and they should be used in the early phase when patients start to have respiratory distress, hypoxemia, and then so outside and inside the ICU, but have not to be used when the patient has not any respiratory signs.
Yes.
So corticosteroids.
Corticosteroids, yes.
Second is coagulation, and I show you our protocol. Very important. This is our protocol, and we monitored the coagulation with the D-dimer and using the echocardiography every day. And then we monitored the factor activated 10 to titrate the anticoagulants. So when the patient has a D-dimer less than 1,000, I don't want to enter in all details of our flow chart, but just the main concept. There were no clinical events. We just gave prophylactic enoxaparin. This means 4,000 units a day. But this is a very minority of these patients, almost no one when they are admitted to the intensive care. Then you have an intermediate risk when the D-dimer is higher than 1,000, more likely between 1,000 and 5,000. In that point, we performed, of course, always an echographic evaluation. And if there was no right heart impairment, we used therapeutic enoxaparin. What does it mean? More or less 6,000 unit times 2 of enoxaparin. If the patients have some risk for right impairment, so some evidence of possible right heart impairment, we always went, and not related to PEEP, we also found that when you use higher PEEP, you have a major impairment of the right ventricle. So if this is not the case, we went to the CT angio and the CT perfusion to see if there was a pulmonary embolism. If the D-dimer is progressively increasing, so more than 5,000, 10,000, 15,000, we got up to 35, 40,000 of D-dimer. In that case, most of case, we moved to intravenous heparin at 20, 25,000 units a day. And if there were some idea that there was some possible deterioration of gas exchange, again, we went to the angio and the CT pulmonary. Yeah. If in case we found a pulmonary embolism, we found almost a percentage of around 7% of pulmonary embolism. We treated this patient with thrombolysis, alteplase, and they were in all patients very effective. After this, we moved to warfarin, and then this coumadin, warfarin, and then we moved at the discharge to the new anticoagulants. While the patients in other cases were maintained with enoxaparin at least for 1 month after ICU.
After discharge, yes.
Absolutely.
So we have corticosteroids, we have anticoagulation,
and the third, yes, sorry.
antibiotic.
But the third is protective ventilation, so moderate PIP, 8-12, tidal volume, the usual. Prone position as a rescue, okay. Nitric oxide if you don't. And then the other point is antibiotics. All right, this is an intriguing issue. I can tell you what we did, discuss with our infectivologist. You can choose also another way. So what we did is to cover this patient with ceftarolone, which is a cyclosporin of 5th generation, which is ceftarolone is a 5th generation, which is against MRSA and gram negative. Okay, why that? Because the reports were really there are three microorganisms that this patient can develop, but not early, late, after the 15 days. So are MRSA, are gram negative, mainly Pseudomonas, more or less resistant, and Candida infection. These are the 3 main infections that the patient develop. But none of them, they have co-infection at the time of ICU admission. Okay,
not sepsis.
So sepsis is not associated with COVID-19. Sepsis is very late. It's a complication very late. So it's not a problem for the first 10 to 15 days of COVID-19. And so we decided to use ceftarolone. And in fact, we delayed the risk to develop co-infection up to the 15-17 days. After 15-17 days, we published just a paper in which you have a risk almost 30 to 50% to develop, of course, infection, but we are talking about patients intubated that you were not able to extubate within the first 20 days.
Moving along.
Other centers decided not to cover for antibiotics. We have no comparison for that. So it's possible that if you don't cover, you can get infection earlier, and this might not be helpful because in that way you are playing all your cards within the first 15 days, because we know that if you are not extubated within 15-20 days, the ICU stay is very long. So our reasoning, okay, we know that we are risk something, but we are trying to pay everything in the first 15-20 days. So you don't get any infection in the first 15 to 20 days. If you are going well, okay, you go. If you are going longer, you can have complication, but you could have complication anyway.
Now we have here a question. There are lots of questions that are now surging, but appearing, and the audience is starting to question. One question to Dr. Pedro and also Professor Paolo. What do you think about the quality of the published science in these 3 months in COVID-19? With the compassionate use of drugs, we saw the film with hydroxychloroquine, with the antiviral, retroviral drugs. Dr. Pedro, what do you have to say about what happened in terms of peer review in the science, in the world science during the pandemic?
Well, I think that it is very important that things get published as soon as possible, even though the process of reviewing is not as complete or as thorough as normally, because I would say that what one has to gain compensates for what we would lose if we could not publish early. So, of course, one has to look at these publications with a different approach, not taking them for granted, but instead to use them to assist us in developing new strategies. Because, for instance, for Paolo, what he is telling us now is something that he learned in just 3 months. 3 months ago, he knew nothing. Now,
Uncharted waters.
learned a lot. and is not waiting for in-depth analysis or for a lot more data or for more fancy statistics. No, he's just sharing what he has observed with some analysis, of course, but knowing that everything can change in 3 more months. So this is an ongoing process. Actually, I'm very curious to ask Paolo about how the management of these patients changed as he acquired more knowledge. Did it change a lot, or did this knowledge not have much of an impact on your practice?
I think that it changed a lot. When we received the first patients, there were patients with all of them equal, with PO2 below 100, chest X-ray, as I told you, more or less injured, very hypoxemic, and what we were told was that this was an ARDS. Okay, that's why we started, and in fact, at the beginning, even we were okay. You have to use a bit higher PEEP. You look at the driving pressure. You have to prone the patients, all this kind of stuff. But then we discovered that this was not the case. It was a completely different disease. And just to share with you this slide that I think is important too, that is a multiple organ disease syndrome. So this is we had affected the lung, the coagulation, the kidney in 35% of patients, the liver, the gut, the heart, the brain, we have also, okay? And then I think that one image shows what is COVID-19. This is our unit, okay? This is Dr. Valbusa, is the cardiologist, coming every day with the echo. Then you see on the back the renal support machine. Then you see in this case an ECMO. We did not do many ECMO in these patients. I don't think it's too much indicated, but in some patients we did. You see the ventilator, you see the pump. This is COVID-19. This is why it's not pneumonia. So first of all, we learned that we have to treat these patients more complex than just a pneumonia. Second, we learned, as I show you by CT scan, that the presentation of the disease is different. And the PEEP, for example, was not so helpful as we believed, as in the traditional ARDS. We learned that prone position is not so helpful as in traditional ARDS. We learned that nitric oxide may help us to learn time. We learned that we have to be maniac in the detection of the pulmonary embolism. That is not the case for RDS. We were very careful in the analysis of the D-dimer, as I told you, and the decoagulation process. We did angiotac in we did almost in all patients due to the fact that when we go to the CT perfusion radiology, then they did all angiotac. So we have also the real percentage of patients.
Paolo, what were the main mistakes that you made?
The main mistake, I think, at the beginning, the main mistake was to use higher PEEP, because we look at some patient improvement in oxygenation, but then we realized that this improvement was not recruitment, was just redistribution of perfusion, but we learned after 1 week, 10 days. The big mistake was at the beginning to be pressed by prone most of the patient, that increased the workload dramatically, and then we learned that it was not so effective. The other mistake was likely that at the beginning we used ASA, so the antiaggregants, okay? Antiaggregants together with the anticoagulants, okay? Because even now there are papers discussing the fact that you have a lesion of the endothelium, and this lesion of the endothelium provides procoagulation and aggregability of the platelets. We found that when we use ASA and heparin or enoxaparin, you increase dramatically the risk of bleeding. And then I tell you where. So we, after 15 days, 20 days, we decided to stop, and in fact, I did not mention that, the use of antiaggregants. Antiaggregants, in our opinion, should not be used in these patients. Only anticoagulants like heparin. Then, we learned is to be very active in the monitoring of two muscles. Mainly the muscle sartorius, which is ellipsoas and sartorius. These are muscles down to the diaphragm. These are the fillet muscles, are the muscle where we take the fillet when we eat. And these are very soft muscles. And we discovered that to monitor this muscle was very important.
How?
Because we discovered, because we found that when we have hemorrhage due to the anticoagulation, we had more hemorrhage mainly in these muscles.
How
so
did
we
you
monitored
monitor
by echo. So we started to monitor in these patients so that we can get at the beginning, if you have a lesion, and you can get at this point, you go to the CT. However, I can tell you this, that what we learned also is that we have to be proactive in the anticoagulation. So usually the cardiologist told us that for the heart, the risk of hemorrhage, if you coagulate more, is much higher and more life-threatening than the risk to have of thrombosis, okay, in their therapy. While we found the opposite. So to have higher risk of hemorrhage was much better than the risk of thrombosis. In other words, in COVID-19, if you develop a pulmonary thrombosis, not macro thrombosis, you are it's very likely to die. The risk to die is very high. While especially if you don't diagnose this very early and you give thrombolysis. While the risk of hemorrhage by increasing heparin, for example, and monitoring with activated factor A is less life-threatening. So all cases of hemorrhage that we had in the sartorius and in the psoas were managed, 2 cases by surgery and 7 cases by endovascular, and all patients survived. So
speaking of muscles, what about the use of muscle relaxants?
So this is another thing that we changed after the first week. The first week they taught us, this was what was coming, information that you have to sedate this patient, to paralyze this patient, to prone this patient, and to use IRP. As I show you, we did completely different. And we clearly demonstrated that we have to manage differently. So you have to use controlled mechanical ventilation and paralysis for a very short time, also because you are giving steroids. And the combination of paralysis and steroids may lead to neuromuscular problem, the CIP. So we used as less as possible neuromuscular blockade. The average number of days was 2.5 in our group, and we moved toward assisted ventilation much earlier. This is another big difference compared to the beginning. So after 1 week, 8 days, we decided to change completely, to change our mind, don't follow the rules or what the rules were coming out, and to follow a different strategy in these patients. So neuromuscular blockade are helpful in the very early phase, but our suggestion to use for as less as possible, go to assisted ventilation as early as possible, especially because you have to combine with corticosteroids.
And what about the brain? Probably you didn't monitor the brain much,
yes.
but what about, for instance, delirium afterwards, which could be used as a way of assessing?
Yes, so we measured in some patients, and we had problems in the awakening, also the virus we measured the virus in the liquor. And we found in 2/3 of the patients with this, in which there was a suspect of something, difficult awakening and like this, we did magnetic resonance, and we did also some special magnetic resonance, and we did also the liquor. And we found inductor the virus in the liquor. We found also the liquor in the peritoneum, everywhere. So we had a few cases with thrombosis, that we found thrombosis in the brain. And that's why this patient has not to be too deeply sedated as soon as you can. And because we have always to control the cerebral function, because the risk to have this microthrombosis in the brain is not high. It's not so high as a coagulation or renal complication, but we have some case report that we sent out with evidence of encephalitis and brain thrombosis. In fact, we did several magnetic resonance for control in this patient if the patient was not awake.
And what about delirium?
Delirium, I can say that we used a lot of dextromethorphan in these patients. So we try to minimize the sedation. So we had, but our impression, I mean, was not higher than other, even if the period of mechanical ventilation is much longer. Minimum is 15 to 20 days in most patients. The problem that you observed is the possible neuromuscular problems in the weaning phase and after extubation. That's probably the combination of the use of corticosteroids. So this might be a problem. Some patients they had, and we measured, of course, the neuromuscular activity and muscular activity. That's why it's very important in this patient, the respiratory physiotherapy. Respiratory physiotherapy played a major role in the weaning phase, in extubation phase, and in the phase after extubation. That's why, as I told you before, it's very important. That's what we think, that you have an area after extubation in which there you can aggressively treat this patient with respiratory physiotherapy.
We have to wrap up. And one final question to you both.
I also have one final question.
Yes, so go ahead.
I go first?
Yes.
Okay, Paolo, as I'm listening to you, I realize...
This is just to give a picture what is COVID-19. The gray and the red, okay? This is COVID-19.
So I think that you are entitled to another medal, not just for helping us in Portugal. And this other medal is probably even more important because I cannot think of another ICU where so much science was performed along with clinical work.
And in an overwhelming time of patients. That's the thing that yes.
Besides deserving a medal for that, I have two questions regarding the scenario that I'm now seeing clearly of all the science being performed along with the clinical work. And the two questions are, how did your colleagues cope with that? How often did they tell you, Paolo, please stop. This is not the moment for doing science. And the other question is, if it was possible to compare your mortality with the mortality of a unit where no science was performed, just the clinical work, did you help your patients or did you overlook your patients because of the science?
So regarding the first question, I can tell you that was amazing. So we were so deeply involved, all the team, even colleagues from anesthesia, within this experience that we stayed in a hospital a lot of hours, okay? We had for 2 months and a half, 3 months almost, just now, the last 15, now we are relaxed. For me, is finished. I mean, for me, I mean, now we're just thinking about reorganization, which is not easy, but we were so much involved that every minute of the day, I can tell you, we were in mind with COVID-19. It was like a person next to us, all of us.
Like a person.
And so we had also a team of young people, as I told you, from residents and some people also very active, that took care, for example, Chiara Robba, Lorenzo Bal, Denise Battarini, very young people, that they helped us very much to do. They went all to do all this CT scan, that because of course you can imagine to go to this very severe hypoxemic patient to CT scan. The radiology staff were amazing. At the beginning, were a little bit what we are doing now. Then they realized that there was something more to understand. So I can tell you that there was absolutely no problem. It was really amazing because people wanted to understand the secrets of COVID-19. And I think that I'm not saying that we understood everything, just this from clinical point of view, but I think that we have our interpretation of COVID-19 pneumonia very clearly, as I showed you before. The second point was what about outcome? This is difficult. What I can tell you, we have almost the last number. Our ICU mortality was 33%, and the age of our patients was 67 years old, because you know in Liguria we have a little bit more older patients. We have younger, older. Just to tell you the question before, patients older than 65 were not intubated. Yes. No, our average age was 68. Okay, so just to give you a clear answer. Mortality was around 35, 34.
How does that compare to similar?
Sorry, and what I can tell you more, the mortality in the hospital after this is zero. So due to the fact that we did this sub-intensive care and we discharged patients after 10 days to the infectious disease and then to home, the mortality in hospital is zero. So only one patient, but he died because he had not problem of COVID. I mean, he had other problems for that. But the mortality was almost zero. So all patients died or in ICU or they were discharged from the hospital. If we can compare, it's difficult. What I can tell you, these were the early data. In China, patient 46 years old, 46, so 20 years older than ours, and I showed you that age is very important. Mortality reported was 69% in the ICU, not in the hospital. In the UK, Wales, and Ireland, the mortality reported 1 month ago, not in recovery study, which is 42 at 28 days, not ICU. Then we can discuss this. But the mortality in the ICU reported by UK, Wales, and Ireland 1 month ago was 68% in the ICU, not at 28 days in the ICU. The mortality reported in many centers in the United States, even in New York, exceeded 80%.
80%.
New York, yes. Other centers, they have lower, around 40 or 45%. But in some centers, Seattle, New York, at the beginning, when they also were overloaded, I don't know, the organization was very high.
That's a nice hint for my final question, and then I will ask you to...
So, sorry, just not to say, I don't know, the comparison is difficult. You don't know what's the mortality in recovery trial at 28 days is reported to be 42% in the control group and 32% in the steroids, but this is mortality at 28, and we don't know how many patients were excluded because this was a randomized trial.
Yeah, but these messages, Paolo, are very important because I think that it stands as an example what you did, because I'm sure that the science contributed to the motivation, and the motivation is key, I believe, especially when dealing with COVID. To me, my experience was that it was always very important to overcome the fear, to overcome the doubts, to overcome that feeling that we were facing something stronger than us. And by using this approach of increasing knowledge, to put it at the service of the patients immediately, to share it with the community outside your country, that probably motivated your team. Nurses probably were also involved. And
that's why emphasize the why was I right when I presented you as both apostles in spreading this word on science and scientific method. My final question and is what are the questions what is unknown now? What are the questions that still remain to be answered? What are the uncharted waters that you still feel the need to get answers in this kind of patients?
I think that probably we have to understand more if there are additional drugs that can be helpful. Some of them has been studied in a very small match control, not randomized, not well powerful data, more or less those that I showed you before. So if there is possible additional help, in addition to corticosteroids, we have to read the recovery trial because these are just initial number. We have to understand more. So drugs, I think we have to understand the immune response, which is not very clear. Most of our patients, after even severe, they did not develop a very strong immune response, and this is very important for understanding the future. We have to understand how to treat in case the patient's at home. This is another, so very early, before the hospital. As I say, the coronavirus fight is not in the hospital, the coronavirus fight is outside the hospital. And this is, you have to probably to understand more what to do there and how to deal with these patients. And we have to understand more about what happens after corona. So just to finish, I want to show you.
Oh, I'm glad you can change that slide.
No, but this yes, because this is a CT scan of a patient after extubation. Okay, after. This is the permission of these patients that he was also he's a physician, he's a pediatrician, also he likes to play, and so these are a CT scan. So we have to understand what happens to these fibrotic lungs in the long term. And this is, we don't know. The follow-up is just started.
Just starting now.
Starting now. So this is important. And
yes.
So these are some of the most questions from our point of view that I think we have to understand more.
Unfortunately, we have to finish because we are more than double the time reserved for this broadcast. Then I asked you both the final recommendation to our audience. And so if Dr. Pedro, can you give us your final recommendation?
Well, the recommendation is for our Portuguese friends who are watching this session, and also a message to Paolo, because if I think of a Portuguese physician who could compare with Paulo Pelosi in the role played facing an epidemic like this, it is Ricardo Jorge, who was a physician that dealt with the bubonic pest in more than 1 century ago. And I recommend that you read the book written by Ricardo Jorge, where he explains how he dealt with the plague here in Porto. It's wonderful. It is really a wonderful example of how to go up to the front line to face the disease, to research, because he had never seen a patient with this disease. He didn't know what it was. He had to do a lot of research as he was treating the patients as well. And this book is a wonderful description that tells us a lot in our days. I'll try to get, I don't know if there's an English translation, but maybe I can do it.
I will check.
Great recommendation.
Can I say just last words from my side?
Yes. Take home message.
We treated just 3 words. At the beginning, we treated the unknown, as Pedro said, something that we did not know before. We could have some information. Some of them were wrong, probably, or not well interpreted. So we treated the unknown. We treated the unimaginable, something that you could never imagine. Actually, right now, we are used to treat other disease, not something like that. And I can say we treated the impossible that you would never expected can happen in the world and in my life. But I think that we learned all together that something like that was an unbelievable occasion to gather all together, not only in the unit, as I told you, but among physicians in the world. I've never seen such a chatting, collaboration, exchange of ideas, good or bad, but ideas and possible new intervention in patients with all media possibilities. This was fantastic. And I hope that this kind of collaboration will and mentality will continue after Corona. So Corona was a serial killer, is a serial killer. It's not defeated right now in the world, even in Italy. We have to be very careful. This is always ready to kill. But I think that was a great occasion to understand that if we can share our ideas, even outside of the papers or outside of the classical methods, it's very important. And I think that was something that will remain in my heart. I will never forget for all my life. And it was the most terrific experience in my professional life with me and all my colleagues in the hospital, in the unit, in Liguria, in Italy, in Europe, and in the world. Thank you very much.
Dear Pedro, dear Paulo, myself, I feel honored to have arranged to have this conversation, because we owe you a lot. We owe you, Pedro, Paolo, you are inspirational for us. I said that before, because the way you share your knowledge, the way you predispose, that's an example, the best inherited gift that you can give us, and the best recommendation that you can give us. So thank you deeply, thank you of that. So I just want to thank all the audience that stood in 2 hours that we are chatting. So thank you so much for your collaboration in your science and your sharing of knowledge.
Thank you very much, and hoping to come to Portugal in much better condition. Porto drinks good wine and good food from Portuguese side.
And you can come to Viseu also. Thank you so much.
Ciao, bye bye,
Wow.
fantastic. Ciao.
Thank you.
Grazie.
Ciao, grazie Pedro, fantastico.